You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or Alexa, what's my flash briefing? I hope you'll join us.
Hi, everyone. This is John Mandrola from theheart.org, Medscape Cardiology. And this is This Week in Cardiology for May 3rd, 2024. This is Kentucky Derby week. The first Saturday in May is tomorrow. Today we'll talk TAVR versus surgical aortic valve replacement, a little bit more on renal denervation, the drug Inclisiran, and marketing disguised as science. Let's start today with the Dedicate DZHK6 trial, or from now on, just the Dedicate trial. This was TAVI versus surgical aortic valve replacement in low to intermediate risk patients with aortic stenosis. German investigators at 38 sites, first author Stefan Blankenberg, performed an RCT of TAVI versus SAVR in low to intermediate risk surgical patients with severe AS. The Dedicate trial is notable for at least two big reasons. One is that there was no industry funding, and the other was that the operators could choose any TAVI valve that they felt would be best. It was a non-inferiority trial with a primary outcome of death or stroke at 1 year. 1 year. That's a problem, and I'll come back to it. In the introduction, the authors write that their trial had broad inclusion criteria, unlike the highly selective PARTNER and Evolute trials. They believe, therefore, that Dedicate will be more reflective of regular practice. Exclusion criteria for Dedicate included patients who had substantial coronary disease and those with bicuspid aortic valves. The trial enrolled about 1,400 patients split evenly in the TAVI and SAVR arms. There was substantially more crossover SAVR to TAVI and withdrawal in the SAVR arm, however. The mean age of these patients was 74 years, and the median STS score was 1.8%, which is similar to PARTNER 3 and Evolute low risk. 2/3 of the TAVI was done with a balloon expandable valve, and 1/3 was done with a self-expanding valve. SAVR was done with full sternotomy in about half the patients. The primary outcome of Dedicate clearly favored TAVI. 5.4% primary events in TAVI versus 10% in SAVR. That's an absolute risk decrease of 4.6%, a hazard ratio 0.53 with confidence intervals going from 0.35 to 0.79, clearly significant for non-inferiority. The death was 2.6% in the TAVI arm versus 6.2 in the SAVR group. 2.6 versus 6.2. Hazard ratio here was 0.43, again with tight confidence intervals. Stroke rates was 2.9% and 4.7 respectively. Hazard ratio 0.61 in favor of TAVI. Pacemakers were performed in 11.8% and 6.7% of the patients TAVI versus surgical. Hazard ratio there 1.81. Prosthetic valve dysfunction was 1.6% in the TAVI group and 0.6% in the SAVR group. Hazard ratio there 2.44. Safety-wise, bleeding was 4.3% in the TAVI group and 17.2% in the surgery group. Vascular excite complications went the other way, 7.9% in TAVI versus 0.7% in surgery. So my comments. I commend the German investigators for doing a trial without industry support. Industry is not nefarious, but industry-supported trials may indeed be more selective and certainly limit valve choice. And trials are good. We should have more trials in medicine. There are, though, very curious findings in this trial. Despite a similar STS score as the low-risk trials, the primary outcome in Dedicate is many, many times higher. In Dedicate, death or stroke was 5.4 versus 10%, but in Partner 3, death and stroke were 1.8 versus 4.9%. As for death, Dedicate, it was 2.6 versus 6.2%. At 1 year in Partner 3, it was 1 versus 2.5%. In Evolute, it was 2.4 versus 2.9%. I do not understand why the rates of death and stroke events in Dedicate were so much higher than in the Partner 3 trials, especially in the surgical arm. I also do not understand why surgical death was 6% at 1 year in Dedicate versus less than 3% in the Partner and Evolute low-risk trials. What's going on with surgery in the Dedicate arm? Dedicate authors posit that they enrolled patients during the pandemic, but I don't see that as a likely cause. They also note that there were more women in the trial, but it was not that much more. It was 44% in Dedicate versus 36% in the low-risk trials. So enrolling more women doesn't seem like a likely explanation. But the main problem I have with this trial is the 1-year follow-up. The accompanying editorial in the New England Journal of Medicine had the title, quote, "Another early win for TAVI in low-risk patients." Author Dr. Shaw was relatively cautious in his closing words, but the title and the bulk of the article were pretty celebratory. Publication of the trial alone in the New England Journal of Medicine is, by definition, celebratory. Now, you can love TAVI, as I do. It is an amazing in advance. But there is now well-known patterns of events. TAVI performs better than surgery in the first year, but there is catch-up in the coming years. I'm going to cite to you a 5-year outcomes meta-analysis, first author, Fabio Barilli. It's in the European Journal of Cardiothoracic Surgery. I'll link to it. And they find that when you look at 5-year results, there appears to be no difference. But when you consider TAVI's early advantage, TAVI performance from years 2 to 5 is worse than surgery. Now, proponents of TAVI will point to the recent Notion 8-year trial results, which found no difference in major outcomes. But I would remind everyone that this included only 140 patients in each treatment arm. The problem with over-enthusiastic use of TAVI in younger patients with AS is that we don't have good long-term data. A 72-year-old person is going to make it to 80 most likely. When they have structural valve deterioration, then what? Now, there's terrible outcomes of removing TAVI valves. You commit this patient who has a TAVI to another valve and valve, and maybe that's possible, maybe it's easy, but maybe not. In sum, TAVI is a great innovation for older patients who have high surgical risk. Its use in younger patients remains more complicated. And trials with 1-year follow-up are simply not helpful in sorting out this question. Putting Dedicate in the New England Journal of Medicine and gifting it a praising editorial has the effect of creating even more therapeutic momentum towards TAVI, and I don't like it, even though I like TAVI. All right, speaking of too short follow-up, let's talk renal denervation. The Target 1 RCT of renal denervation using an alcohol-mediated ablation technique was also presented at ACC, and it made it into circulation. The idea behind renal denervation is an interesting one, right? You ablate sympathetic nerves, it reduces blood pressure. This could be a huge development because hypertension is a major public health problem, and many humans struggle to take pills on a regular basis. So if you could have a non-pharmacologic way to control blood pressure, it would be awesome. Now, an ultrasound and RF ablation device have been approved already for renal denervation, though I have opined previously that both of these are marred by modest reductions in blood pressure and the lack of a sham control data beyond 6 months to a year. And of course, blood pressure therapy is not for 6 months or a year, it's for decades. Well, the investigators in the Target 1 trial had the idea of using alcohol into the perivascular space to achieve circumferential ablation of the afferent and efferent sympathetic nerves. Now, for the record, Electrophysiologists can use alcohol within epicardial veins, and boy, does it ablate tissue a lot. For AF ablation, we often inject alcohol into the vein of Marshall, which is a branch off the coronary sinus, and then you see ablation downstream from that in the region of the mitral isthmus up to the anterior ridge between the appendage and pulmonary veins, and it is an impressive amount of ablation with alcohol. However, in the sham-controlled Target 1 trial, wherein 300 patients were randomized to sham or alcohol renal denervation, the mean ambulatory systolic blood pressure reduction at 3 months was only 3.2 millimeters of mercury. And it was fairly similar for office blood pressure measurements as well. The results made statistical significance at a p-value of, sit down for this, 0.487, which makes me laugh that they carried it out to 4 decimal places. One of the notable things about the results was the sham control arm got a 7 millimeter reduction of systolic blood pressure. Sham, 7 millimeters. This to me emphasizes the importance of having sham-controlled arms in any procedure trial. Now, the authors write about how patients were allowed to take multiple medications, up to 2 to 5 prescriptions. About 20% of patients in this trial were on aldosterone blockers, which are highly effective, and this may have mediated the modest results. And I don't know, renal denervation is a great idea, but the reductions in blood pressure so far are quite small. This trial provides extremely modest reduction at only 3 months, and I suspect this is likely to get even lower at longer follow-up. Now, I've already seen advertisements from hospitals and those unseemly media pics where doctors pose with shiny, happy industry reps announcing their first renal denervation procedure. To me, these sorts of pictures, whether they're for renal denervation or left atrial appendage occlusion or ablation, are unseemly, unprofessional, and I wish my colleagues would refrain from public celebration alongside industry. In the matter of renal denervation, I am pessimistic but not closed-minded. But what convinced me is extending sham-controlled follow-up. Proponents say it's not possible, but I disagree, and I think it's absolutely necessary. As for alcohol-mediated renal denervation, I would estimate that this is the first half of a mile of a 26-mile marathon. There is much more work ahead before this becomes accepted. All right, next topic is a trial called Victorian Initiate. Last week on This Week in Cardiology, I spoke about surrogate markers. It was in regard to a rather technical paper in JAMA on how surrogate markers often have dubious connections to overall clinical outcomes. Today, let's go over an example of such a trial presented at ACC. This was called the Victorian Initiate trial, which made it into the Journal of the American College of Cardiology as a simultaneous publication. I'll tell you about this trial for multiple reasons. One is to highlight the limitations of surrogate markers, but the other is to show you a classic example of a marketing study that masquerades as science. Now, the drug Inclisiran is a small interfering RNA that inhibits hepatic PCSK9 production, which then raises hepatic expression of the LDL receptor and increases LDL clearance. The Orion series of trials with Inclisiran shows that the twice-yearly injection lowers LDL cholesterol. A lot, actually. But none of the Orion trials had clinical endpoints as a primary endpoint. All we know is that Inclisiran lowers LDL cholesterol. Novartis, who makes Inclisiran, benefits from the drug gaining FDA approval. But as far as I can tell, uptake seems low. Probably because of cost, or perhaps my colleagues are worried that there are no clinical outcomes data with this drug. Anyways, there was a big Inclisiran study presented at ACC. Now, you might think the company would want to show that the drug reduces outcomes in patients who have atherosclerotic vascular disease. Well, no, there was no such study. Instead, we hear about Victorian Initiate. This is a trial of 2 strategies to get patients who have cardiovascular disease and are not at goal LDL cholesterol to get to goal LDL cholesterol. Only 450 patients were randomized in a number of centers. One group gets Inclisiran first, and the other group gets standard of care, doctor's choice, which may be nothing, maybe ezetimibe, maybe a PCSK9 inhibitor, or bempedoic acid, or any combination of the above. Now, voila, Novartis succeeded in getting a positive trial. The Inclisiran first strategy led to a significantly greater reductions in LDL cholesterol from baseline to day 330 versus usual care. It was 60% got to goal LDL versus only 7% in the standard of care arm. They also reported that statin discontinuation was not significantly different in the two groups. Novartis also won because they received positive comments from the floor at ACC. Discussant of the study at the ACC meeting, Dr. Jorge Plutsky, Director of Preventive Cardiology at Brigham and Women's Hospital in Boston, called this, quote, an important study that provides another important example of stunning undertreatment of high-risk patients and coupled that with a really innovative approach. I should also quote this from the Journal of the American College of Cardiology, quote, Victorian Initiate was funded by Novartis Pharmaceuticals Corporation. First author, Dr. Koren, is an employee of a company that received PI fees for his participation in the Novartis Victorian Initiate trial, and that has received study grants and consulting fees from multiple manufacturers of PCSK9 inhibitors and other treatments of lipid disorders. I would also add, multiple authors of the paper had received funds from Novartis, and 4 of the authors are employees of Novartis. Now, comments. Let me concede a couple of things. First, the drug Inclisiran lowers LDL cholesterol via a PCSK9 mechanism, and PCSK9 inhibition has previously shown modest reductions in non-fatal cardiovascular outcomes. I would also concede that Inclisiran is easy to administer. Twice-yearly injections are quite nice. I also concede the causal role that LDL cholesterol has in atherosclerotic vascular disease. But, my friends, LDL cholesterol remains a surrogate marker. And Novartis has a ton of money. Why regulators did not compel them to do a trial powered for outcomes is hard for me to understand. Maybe someone could explain it to me. While it's likely that Inclisiran lowers cardiovascular events, we don't know. A Victorian Initiate could have enrolled 25 times more patients and then measured whether the extra cholesterol lowering one gets over standard of care results in lowering of cardiovascular events. That's what we need to know. As an aside, the trialists report event rates in the trial of about 2% in both groups. Obviously, it's too few to say anything. And without outcomes, we can say nothing about cost efficacy. I don't get it. I don't get why we allow unproven drugs on the market. I don't get why ACC places such a marketing trial in a high-profile status. I don't get why JACC publishes it. I don't get why doctors are accepting of low evidentiary support. Why does bempedoic acid, for instance, get studied in clear outcomes with its 13,000 patients in clinical endpoints, and Inclisiran gets a pass? I am asking. Feel free to let me know. Okay. I'm going to cut it short today because of my voice, but I want to point you to a provocative study in Circ Outcomes. The first author of this paper is Matthew Durstenfeld, and it's which they aim to emulate a trial of early coronary angiography with a new heart failure diagnosis, right? We see this all the time. Somebody gets diagnosed with heart failure, and the common thing is to go for coronary angiography. They used observational data to try and emulate trials, and I enjoy this kind of effort, and I'll have more to say about it next week. Circulation also has an observational study drawing patients from the Women's Health Initiative trial, which is a really important study. This observational study finds an association between perfect systolic blood pressure, like 110 to 130, and better survival in older women. It has drawn the attention of some big names in cardiology, but I find aggressive blood pressure therapy in the elderly a substantial area of harm. So tune in next week and I'll talk about these 2 studies. Also, next week is Heart Rhythm Society meeting in Boston. I have a Hyde Park debate on left atrial appendage occlusion. I say, gosh, not again. I've lost this debate on 5 continents, and I'm sure I'll lose this debate again. But anyways, if you are in Boston, please come say hello. And as always, if you like this podcast, please take the time to give us a rating. These things help others find us. If you have a comment, you disagree with something or something to add, please go to the heart.org website and leave a comment there. And I enjoy learning from my listeners. Until next week, this is John Mandrola from the heart.org, Medscape Cardiology.
You're listening to This Week in Cardiology from the heart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.